You've only got one machine, one probe, and one shot. If you are the only one who knows how to use ultrasound, then you are the expert.
You are listening to Soundwaves From the Community with your host, Dr. Tyler DeShawn.
Hello, and welcome to the next episode of Soundwaves From the Community podcast. I'm your host, Tyler DeShawn. So today's case is somewhat of a continuation of last week's case. Last week we had a patient come in, bit by a spider, probably not heroin, who knows. But we were able to identify that the patient had cellulitis and not abscess because they had cobblestoning. Well, today I'd like to contrast that with a case of a patient that did have an abscess. So this was a younger patient in his 20s, and he had had a pilonidal cyst occur several times in the past in the gluteal cleft. And his presentation to our community ED just south of Colorado Springs was that it had gotten larger and was actually extending into the right buttock. This had been progressing over several days, and he was actually having some purulent drainage from the area of the gluteal cleft, but not a lot laterally. And it just kept getting more painful and more swollen. And so he came in to have it incised and drained. And I believe he'd actually been seen earlier in the day at urgent care, and they recommended that he come to the ED for incision and drainage. And so when I got the patient prone and got a good look at the area that was affected, he did have what appeared to be a pilonidal cyst. He had a couple small pustules that were draining some purulent material out. But there was a huge area of induration extending across the right side of the buttock. And there was no drainage here, but it was very indurated. It was erythematous. And there appeared to be some fluctuates in the center, but it was difficult to tell how much of this was cellulitis and induration and how deep an abscess may be if there was one present. And so I got the ultrasound out and put the probe on there, and actually immediately towards the area where the pilonidal cyst had been, it was mostly indurated. There really wasn't a lot of loculated fluid or anything. And that was probably because of the areas that had already started draining spontaneously. But as I started to slide the probe laterally towards the buttock on the right side, you could see a decent abscess pocket. And so I'm going to show this video clip here. And what you can see is that the patient actually has some purulent material inside the fluid. It's not nice and anechoic like a cyst or the bladder would be, where it's just fluid-filled and nice and black. There's some cellular debris. It's more hypoechoic. And as I press on it, you can actually see the purulent material swirling around inside the abscess. I call that the swirl sign. It looks like some material inside of a washing machine swirling back and forth. And so it was fairly obvious on the presentation that the patient had an abscess. But what was not obvious is where it was or how big it was, and if this was something that extended so deep that he would actually be served better by going to the operating room and having this surgically drained. But I was able to identify that the pocket wasn't too large and where it was exactly, and then I was able to mark the areas to incise so that we could get the purulent fluid out. One thing that is also important when using ultrasound to identify an abscess is to look and make sure that there are not any significant vascular structures where you're going to be incising and draining. This is especially important in patients that have abscesses that, for whatever reason, just happen to spontaneously grow and develop where the patient has a nice large vein in their antecubital fossa. Could be a heroin spider, who knows? But when you're looking at those areas and you're suspecting IV drug use, or if it's just a large abscess, go ahead and throw the probe on. And one other modality that can be helpful is color flow Doppler. And what color flow Doppler does is allows you to detect flow through a box on the screen. Color flow works on the Doppler principle, and we're not going to get too deep into physics. That's not the point of this podcast. There are other resources out there. But it is important to know some physics, because the Doppler effect is the shifting in sound waves as they get closer to or further away from some sort of target or standard. In this case, the standard is the probe, and the sound waves are going either toward or away from something that is moving and getting closer or further away. So if you're completely perpendicular to a vessel that is running across the screen and your sound waves are coming down, you should technically have no flow whatsoever, because the sound waves are not going towards or away from the ultrasound probe. So there are ways that you can change the box so that it's angled, so that way the flow is at least somewhat going towards or away from your sound waves. And this will make them blue or red. And again, this is deeper than we're wanting to go. But if you see color flow going through something, then that is not just an abscess. It is not a cyst. There is some sort of vascular structure there. And so if there is, arterial flow that's pulsatile or more smooth venous flow going through the center of your abscess, you need to be very careful or have a discussion with surgery about the safest way to incise and drain the abscess. Using color flow is important for another reason, because there are mimics to abscesses. So if you've got someone who's got what appears to be an abscess in the neck, in the axilla, or down in the groin, I would always turn on color flow if you're suspecting an abscess, because lymph nodes, when they get enlarged, they're very vascular, so they're going to be very hypoechoic or even anechoic, depending on how high your gain is set. And most lymph nodes do not need to be incised and drained. The reason that they are enlarged is because there is some sort of soft tissue infection around them. If you treat the infection, the lymph node is going to shrink. And so if you put color flow on a structure that looks to be an abscess in those three areas, again, the neck, the axilla, or the groin, and you see what looks like a Christmas tree lighting up, that is not an abscess. That is a lymph node, and you want to avoid incising and draining that. So back to our patient, I did put color flow on the abscess, and there were actually some small vessels in the periphery, but in the meat of the abscess where we're going to be draining, there was not. And so I knew that I could safely incise and drain this abscess, and I knew exactly where to go. There was an article that was published in the Critical Ultrasound Journal in 2012 that actually compared ultrasound sensitivity and specificity to CT scan for superficial abscess. And while there were some limitations to the study, they found that ultrasound was actually more sensitive than CT for diagnosing soft tissue abscess, while CT was more specific than ultrasound. But one of the best papers that I've read recently was discussed on last week's episode about cellulitis and abscess and how ultrasound changed the clinical management. Again, you may know that there's an obvious abscess, so it may not change your decision to incise and drain the abscess, but it can change your approach on where you make the incision and if you decide to get surgery involved or not. I've been surprised when I thought there was an obvious abscess and it was mostly induration, and if I would have cut where I thought it was, I would have missed. So it still can change your management even if there is an obvious abscess present. So do I use ultrasound on all my abscesses? No, but I do use it very frequently, especially when they're extremely large and it is not clear where the center of the abscess is. So again, I would give ultrasound and abscess 2 thumbs up. So get out there, scan your patients, and every shift get 1 scan. And this is key. If you do not scan, you cannot learn point of care ultrasound. Ultrasound is learned by getting your hand on a probe and by putting that probe on a patient, whether that's on their chest or on their butt. Get probes on your patients. Take care, and we'll see you next time.
Stay tuned next time to hear Tyler say,
Wait, so you're telling me you did a fascia iliaca block before the x-ray? Nice. So no narcotics and no Narcan. We are committed to serving you, our community ultrasound brothers and sisters. If you find this podcast to be of great value, please subscribe on Apple Podcast, Google Play, or Stitcher, and please leave us a review. If you have a specific request or feedback, feel free to email us at communitysoundwaves@gmail.com. You can follow us on Twitter at Megasound, MEGUSOUND. Stay healthy and be safe. I don't always use ultrasound, but when I do, it makes a difference. Keep scanning, my friends.